The best is yet to come. Your best is inside of you. Your best is yet to come. Your best is inside of you.
Good evening and welcome to another episode of The Best Is Yet to Come. I am your host, Stephanie Seigle, and we have another awesome show lined up for you. However, before I introduce our guests, I would like to just say to our newcomers, new viewers, welcome. And also to share with you the platform of The Best Is Yet to Come is not only to be a resource to the community, but shed light on things that are affecting our community. That's not enough. We do not stop there. We like to come up with solutions, resolutions for these issues, and that's done through having guests on to share their own personal experiences or either the career path that they have taken to give back to the community. So tonight is no different. I would like to now introduce our guest. He's from Recovery Connections of America. Welcome, Greg.
Thank you very much.
Yes, it's a pleasure to have you. I had the honor to speak with you last night, and I'm so excited about having you here.
Thank you.
Now, tell us about Recovery Connections and when was it founded and what was the vision and where you're at with that vision.
So it was founded approximately 6 years ago in Providence, Rhode Island by Mike Breyer, who's the current CEO, and his background of needing to try to help people when he fought himself into recovery in trying to then find a job, that he decided that he could make a job on trying to help people and started Recovery Connection Centers of America. We sometimes just call it Recovery Connection Centers for just simple form. And it's a outpatient Suboxone Sublocade Vivitrol, or known as MAT, recovery treatment. And we started that about 6 years ago. It has now expanded into Massachusetts to approximately 16 other facilities.
Yes.
And we are continuing to even open up more. So we range from Cape Cod and Hyannis to Burlington, Mass, all the way out to Springfield, and all parts in between.
Okay. I was doing my research and I thought it was 14 when I heard you say earlier that it was 16. I'm like, oh, okay, so 2 more. That's definitely great. Now, let me ask you this. The vision was, well, the mission statement, the mission of Recovery Connection is?
Oh, I'm not going to be able to recite it right off the... We're seeking to help people in need in opiate recovery, and we can treat with alcohol addiction as well. It is to reach all populations by taking all insurances, all state insurances, as well as military insurance, to treat people in a different way than what has been treated. And that is that we are a very small approach treatment facility. Our size are about the size of a fingernail salon, with 1 doctor, 1 manager, and 1 counselor. So people come in and don't get overwhelmed by experience of a large facility and uncomfortable sitting in a large waiting room with others that they might have known in the past. And now they feel more comfortable because it's less likely that they're going to possibly bump into someone they used to know. And we provide a safer, comfortable environment for them. And that's one of our visions, is to break the stigma by of treating opiate dependency, is to try to treat people where they are at and comfortably and safe.
Great. Now, one of the things that when I was, doing a little research, one of the requirements is that they get into counseling. Am I correct?
So if they're coming in to meet with our provider, we have doctors, we have psych nurse practitioners, or nurse practitioners all certified for buprenorphine. Once they've seen the provider, they immediately leave that room, and the counselor's right there for them to talk to. Not everybody wants to speak to a counselor at the beginning, and they don't. If they waive, hopefully not just with one finger on the first time, but maybe you get all five the next time, and then maybe the counselor will then engage them further. But every time that they come in, they can sit with the counselors. It's not mandated, but our counselors know to try to reach out in a humane way of saying, hey, I just want to check in with you.
Okay.
And hopefully we can start building on some of their supports that they may need now that they're getting themselves clean.
Now, what are some of those supports that you've seen?
So that's a great question, because the toughest part in recovery is that you've come into a facility, you've got a medication called Suboxone or buprenorphine treatment or Vivitrol, and you get some counseling, and now you got 20 days or maybe a week or 2 weeks or a month between the next appointment to you're on your own. So we utilize community resources like in Brockton, the Statewide to Recovery, a community base of clients, of people in recovery trying to help them other people in recovery. We use those services. Sometimes there are insurances. If there's a commercial insurances, there's a number of different commercial programs in the state that people can go to that get a little bit more extra background because of that insurance.
Okay.
We also use an app. It's actually a prescribed app called Paratherapeutics that the client is downloading on their phone, and on a daily basis or a couple days a week that they go over these questions about their recovery to keep them engaged in their recovery. But it's a token economy. If they complete those, they get money from the state. Medicaid clients are allowed to do this, and they'll get actually money for going on further and further. And it gets more involved. So this is kind of something we're looking for technology like this to try to keep that client engaged in their recovery day to day. Of course, we're going to encourage them to AA and NA support programs as well. And many times if we receive a client from a long-standing recovery program, they also want to stay engaged, and they might have some evening Zoom therapy calls or group calls together, and we want them staying in. So we really try to reach and not just be a one visit appointment, is to try to set them up with a treatment plan as well.
Great. Now, how often does a client come in weekly? Is it?
So normally on a buprenorphine treatment model, a client will be coming in on a week-to-week basis.
Okay.
They're giving you urine screens for the primary purpose of to make sure that buprenorphine is present in their urine. It's called norbuprenorphine. That means we can see it's a metabolite that's there. If that client is also experiencing with other medications, should we say street drugs, that we're aware of it, and we're going to the counselors know to work on that as well.
Okay.
If the client starts really engaging in recovery treatment and has what we call negative screens, there's no other thing other than norbuprenorphine, the doctor and the counselor work together to say, let's go to bi-weekly and then get up to once a month. Because it's a controlled substance, we have to only can get to once a month on the oral medication as well as the injectable form now.
Okay.
So it's a path that way. If a person has been doing really well and all of a sudden slips up and finds out we see fentanyl in there, it's not punishment. We try to re-engage them even further and bring them back down to maybe weekly. But a person also can go up to once a month for the medication, but to still see our counselors weekly.
That's great.
So,
because one of the things that I definitely advocate for, I mean, I'm in the field, and I think that, it's so much work, as I shared with you last night, that we still need to do. And I feel a lot of times what does not happen, they are connected with like the MAP programs, other program, but no counseling to deal with those underlying issues. I often say that no one will wake up and say, okay, I want to use drugs, or I want my life to spiral out of control. So there's definitely had to have been some type of trauma, I believe, that has caused this to happen. So I think that's great that, you all do provide counseling.
Right. So those counselors also, and part of my job as a business development director is also going out to all these different types of facilities, from mental health facilities to urgent cares to hospitals or emergency rooms, and to long-term opiate recovery places, saying, here, we can take this population. But our door is open for that person who walks in, says, my life is spiraling out of control. And when you've started a buprenorphine treatment, and all of a sudden you see that they use the drugs as a mask over a major issue.
Right.
be it a PTSD trauma attack or loss or family loss or depression, that we evaluate that as well. We do have psych nurse practitioners that can help with low mental health issues from
Okay.
depression and anxiety disorder, but they are connected immediately if we see something else in the psychiatric world that they may need a higher level of care. And because my history of background of mental health of 20 years in mental health agencies, I know many of them.
Okay.
And we would reach out to those specific specialties to make sure that the person is getting psychiatric support, and or if they can transition completely. If that psychiatric support doesn't have buprenorphine, we can work with them.
Okay. Now, I know you said that there are 16 sites as of now. I also read something last year where the CEO in 2020, oh no, yeah, 2 years ago maybe, in 2020, said that his goal by 2023 was to increase, because at this time he saw a rise, I think 32% increase in overdose. And I know we've seen a lot of that, especially with COVID. People are using it more and more as an outlet. Where is he at with his mission and goal?
Well, that's our mission, is to almost on a monthly basis, we're opening up a new facility.
Great.
And getting the rights to do so. I was in New Bedford task force yesterday or 2 days ago, and the increase of the even overdose and increase of death rate is climbing again.
Right.
And they had thought that Narcan would actually decrease it, but there's other populations nearby that are continuing to have this increase of overdose deaths. We are targeting it is to the influence of fentanyl on the streets more, and having fentanyl being across the board, being spread on all different types of medications on the street. People thinking they're having Adderall or speed or cocaine, or even their marijuana, if it's not bought at a dispensary, may have fentanyl on it. And where people unknowingly are trying to do something, they think they may be doing speed and there's fentanyl in it, and they're not used to having an opiate in a high dose, and they're passing away because they thought they were getting something else. So we combat that with test strips, giving clients free test strips to test their product beforehand. We don't want them to use, but
Right.
just to know that. But it is almost known now that if you're buying something on the street, it has a high potential rate of having fentanyl in it.
Right. You know, I share this with my guest. My background is abstinence, so I was a little, when it comes to harm reduction, but more and more, I'm seeing the benefit of it. Because people, of course, like you just said, we would rather they not use, but that's not the reality for some people. So if they are going to use, I feel like we have an obligation to ensure that it's done in a safe, possible way that there is. And it seems like that's what Recovery Connection.
Correct. And we support, in Rhode Island, they've actually passed a law recently to allow 3 or 4 safe zone sites for people to come in to use their product in front of a nurse, of a safety person, to be able to test the product before that person, but give them a safe zone so if they do overdose, there is a nurse nearby. Of course, our support there is of giving them alternatives of different programs that they could then also, if they decide want to not use, and they can go to a program, that's where it's there. I think what you'd said at the beginning when you were saying about MAT and people recognizing or coming to grips with medicated assisted treatment is when you separate out the dependency, your body medically having a dependency on a medication, similar to like if someone is a cigarette smoker and stops cigarettes, you have a response. If you have an opiate issue and you stop, and you'll have a response, withdrawal symptoms. We have medications to prevent that craving, the urge to use. That is not recovery. We have medications to prevent that urge and actually block other opiates from coming on board. Recovery is when you sit down with a counselor and address the issues of the reasons of the why and what you need to do to build how to reclaim your life and recover your life.
I like that.
So that's separate. Hopefully people understand that part of MAT.
Right. I like that because I had a guest on a few weeks ago, and she still had the mindset of, enabling with the harm reduction. So I'm glad that, you said that, you know.
Great.
So that's good. Now, let's talk about well, first let me ask you this. The new program, are you seeing a lot of people taking the advantage of in Rhode Island?
It hasn't fully come to fruition.
Okay.
So they're trying. I don't know. I actually haven't been to one of the sites yet,
Okay.
but I know they're still, even though the state passed it, it's still trying to make sure that we have that. And I'm not exactly sure if the site has been put up yet.
Okay.
So.
Now, did you see any resistance with the community?
Well, immediate resistance was that it was attached to a late night COVID meeting in the State House and a bill that went through, and the next day there was a lot of radio chatter.
Okay.
And the Senator Miller went online. I went on the radio line as well, showing our support of why it was true, and it's a lot of people like, wait a minute, why are we supporting addiction? And the new words in the past 5 years to 7 years is harm reduction approach. And the word harm reduction approach is actually for the professionals, not for the client.
Right.
Client just needs help.
Right.
The word harm reduction is for professionals to realize we need to meet where the client is at and put our hand down and educate them for them to make a choice.
Right.
We still don't have the right. A person has still free will.
Right.
And that's where the difficulty is. How can I stop him from doing that?
Right.
We can't. We just have to keep our hand out and keep educating him to help. So harm reduction is what we do. We never kick anybody out of our program. If they're using, we want to keep them coming. Why
Right.
would we want them out?
I like that you said that. I had another guest on, and she's, with the harm reduction model, and she said trauma is a gateway drug. And when she first said it, I'm like, But then as she explained it, she also said something similar to what you just said. Active use can save lives, especially if they're, using and they're coming to centers that are out there, are still seeking out that support.
Right.
And I said that's definitely so profound if you look at it like that and take away our biases that we have,
The history of having professionals saying he's not ready yet. And I said this yesterday at another meeting. Clients don't fail treatment. Treatment approaches fail clients. And the professionals need to recognize that. Administration and the people and the doctors need to say, how can we pivot to reach that person?
Yes.
And that's what helps the client. Not, we set up everything for that person to win. Not everybody's the same.
Right.
And if you're not able to pivot to saying, let's meet them where they're at and give them what we can.
Right.
And then they have a best shot. Clients can go through a number of different facilities. Sometimes working with a male works, sometimes working with a female works.
Right.
Maybe finding someone in a transgender or a gay population that may be more comfortable. We need to reach out to that person to where is going to be the best fit for them.
Right.
As well as medications approaches.
Right. Right. Now, are you connected with these different entities that you just mentioned in terms of referring out?
So from mental health centers, what my job is to make sure from different mental health agencies nearby, or many times of a number of, if a client come in and is so in need that there's such chaos that they need detoxes. So I'm working with those detoxes like Morton Hospital detox, and that a person may need to go in to really, they're so unsafe and they're willing to go into a detox. So we refer up for those supports. And then they may come back to us. Majority will then return back to us. If there's a different plan or something else is discovered, they may need a different type of service. So definitely going to connect to those types of services in the community.
Okay. Now, I know you and I talked about this yesterday, and I was also reading it with methadone. That's not the approach that recovery center use, am I correct?
We are not we do not prescribe methadone.
Okay.
Methadone has been an incredible medication that was the only thing available for people with opiate issues and pain issues since the 70s, 60s and 70s. And it has been an approach for a number of years until buprenorphine was legal to use and to license and have it prescribed in outpatient facilities, providers, doctors, internal medicine. Anybody that had an MD, DO could then prescribe buprenorphine, office-based treatment for care. But methadone does have its place, does have a population that needs to be on methadone from the structure of how it is prescribed and how it is followed. My hope is that other alternatives are utilized first because of the restricted nature that methadone has, that you want to be able to try to give the least restricted medications first before then going on to something that they may need.
Okay. Can you share with the audience some of these restrictions around methadone?
Well, on a daily basis, they are to come in, and they are expected to have, some will have to have monthly or weekly payment to do that. On a daily basis, they may have to go in at 4, 5, 6, 7 o'clock in the morning and stand in line or come as a big group in the early mornings. Most of them open up at like 5 o'clock until 11 o'clock to get their daily dose. And sometimes the client will have to do that on a daily basis before they can have a take-home that may take 6 months or a year to gain the ability to do a take-home. And there, again, for people that need that structure on a daily basis to address their addiction, yes, that's what they need. And I think the only thing I have the most difficulty with is the approach that methadone has taken by having that high volume amount of people standing outside waiting to be treated. I'm not against methadone by any means, but I am part of the approach and having that. We have had stories and stories of people having to, that you have that many people that have used in line and people coming out that there's stories of misuse and abuse and diversion that has there. So that I would love to see the industry change that so they could use methadone in a proper way and less stigmatizing, because I think the population as a whole sees that, and that if you're in line and people are driving by, it kind of breaks you down.
Absolutely.
And I want to hand people up.
Right, absolutely. I agree with you. Even, you know, our homeless situation, that is definitely have gotten out of control, and it's something that, you know, we still have a lot of work there too. So think about someone that's homeless and they are on methadone. They may not was able to sleep the night before because they're out in the street. They missed their appointment.
Yeah.
And then it's like they have to start over, correct? Or how does that work?
Again, I don't work the methadone system.
Right.
I only know it from when I was an addiction specialist in a mental health agency. And a person, if they start doing drug tests through them, and if a person starts using other drugs, they could be asked to leave to come off the methadone because they're not following through with treatment.
Right.
And which would then leave that person to go back to using street drugs for their opiates.
Right.
Methadone is a synthetic opiate to try to stop the body from urging and craving throughout that day. So if they miss a dose, they're going to experience uncomfortable, and it's very difficult withdrawal from opiates, and definitely from methadone as well.
Right.
So it is a very restrictive and very time consuming, and you almost have to live near that methadone center. And I've seen cars come up in BMWs to bicycles to walkers and buses to get there in the morning, and have to do that.
That's one thing I often share with the audience, because there are people out there that have not personally experienced, you know, whether it be a family member themselves. And what I tell them, that's one thing that does not discriminate against anyone. You know, so I feel like we definitely need to show more empathy and compassion instead of sympathy, because I feel like we come from an empathy background or position. We're more engaged to help to make that difference.
And words words matter, and the industry is really stepping up to change the verbiage to allow people to use uplifting words of recovery, similar to what people understand as drug court,
Right.
is now going to be called recovery court.
Oh, I like
Now,
that.
if you're going to recovery court as a person, I'm going to seek help. I'm
Right.
seeking that the people there, even the judge or the probation officers, trying to help me find recovery. I'm going to drug court. Yeah, I got caught selling.
Right.
I got caught using. So just the verbiage.
Right.
So if we can have the nation learn and more supportive and use less harmful verbiage and supportive. Now people use in AA, I've been in long-term recovery. Instead of I'm an alcoholic, I'm a person of long-term recovery.
Right.
That's uplifting to say. It's an uplifting thing for someone to hear and get support, like congratulations.
Right.
I'm an alcoholic.
Right.
And you can still use that, as many as my oldest brother will use that. He hasn't, at 72 and
Right.
35 years of sobriety,
Right.
he still uses that's what was used. So,
Right.
but now the verbiage matters. So if we can change some of the verbiage, not just for the clients, but for the population,
Yes.
it will hopefully take away some of that stigma
Right.
and that downtrodden look at people instead of handing them up.
Right. When you say that, I think about a client that I have, and he uses that same term. He's probably in his late 60s, mid to late 60s, and he says that I'm an alcoholic. And maybe the first 3 session or 4, okay. And I said, stop saying that. Let's find something else to say, because I believe you can say something, talk yourself into doing things. You speak positive things, you'll get a positive reaction.
Right.
But the more negative that you speak, you begin to buy into that, and your actions will dictate
Correct.
that. So I definitely, it's great that the verbiage is changing.
Right.
Like, what is it? We were big on drug addiction, and now it's substance use.
Right.
Right, right. Now, in your position, what exactly do you do with recovery
So,
connections?
as a business development director,
Yes.
I have a number of hats as it's been changing as we've been growing so
Okay.
exponentially in the past couple of years.
Okay.
Is to connect our services to other services for them. We understand that we can connect to detox centers and do aftercare and be a priority, that a person doesn't have to go to a large facility, and that we have our small piece of pie. Our
Okay.
approach of our small approach may be comfortable for some population that don't want to be seen as much or can go into an area. But connecting to emergency rooms, I'm connected to the courthouses as well as the jails
Okay.
and the probation and parole officers and the recovery courts. Instead of going to jail, that the judge says, hey, would you willing to, instead of me putting you in for 20 days, would you be willing to go into recovery treatment? And then we can take them in that day. So we're working to actually educate, and my job is to help educate those courthouses that we have immediate access.
Great.
And that's what it really comes down to, is access. So even for long-term facilities or large ones that may be out in the Berkshires and these wonderful places that if people have big insurances and they're out for 30 days and this wonderful experience and get their momentum going, and then they come home, that we can be local to them,
Okay.
that they don't have to go far to receive a supportive outreach. So
That's great.
as well as emergency rooms. If someone has been Narcaned over the weekend, we work with Taunton Police Department, who has an outreach of officers that go out at night in their plain clothes after a Narcan's event to meet that person again at their home and say, hey, I just want to check on you.
Oh, that's
You want to
great.
see treatment, and then they can refer to us the next day, and we can get people in. So a number of different types of municipalities have different approaches on how they're dealing with their isolated population of addiction.
Okay.
But they don't know that I'm across all their Zoom calls and their
Right.
meetings, and those connecting those dots even further to know where they're, and we're part of the process to get people help.
Now, I like that the police is involved in that manner. Now, is there any other towns or city that you see, or you all are hoping to move to have that same approach?
Well, I can pollinate those other officers. Is like in Springfield, they do
Okay.
the same thing.
Great.
In Worcester, there's some outreaches, and there's in Taunton, in the Brockton area, there's actually a community health center that has a homeless van that goes out to homeless shelter encampments to reach the people right there. So that each one has such a different. So the more I can tell about Springfield, hey, you know what they do over here, and they can try to and getting them all on different types of Zooms, and there's a lot of there. So we get to cross contaminate with ideas
That's
across the
great.
state.
That's great. Because I strongly feel like it's going to take all of us to do that, do what needs to be done. So that's great. Now, any resistance? Let's talk about that within the community.
Well, so the communities at times are concerned on what they've seen in the past,
Okay.
or what they see in Boston,
Okay.
or large cities of what has been treatment and what they've had to see as they're driving down the road. And they're concerned when when we try to come in, and the town council is very concerned because they don't know us. We're an outsider.
Right.
And we've been growing, but we're still an outsider. So there's a lot of, the word is NIMBY, not in my backyard, send them away,
Right.
send them, I don't want them here anyways, I know we have a problem, but not that big, send them down somewhere else. Or they're worried that we're going to draw more people in, addicted people into their town, recognizing they're already there.
Right.
And that resistance, we've had some difficulty at times with town councils, but we also remind them we're under the ADA rule, which is the Disability Act rule, that we work for clients that are in the disability forum, and that we have the right to provide care and recovery treatment in their town. And then when we've got into towns, and we didn't have resistance to Brockton, but we had local areas very concerned and voiced it.
Okay.
But since we've been there, now they knock on our door and say thank you. Now I know what's going on,
Yes.
and I can see how wonderful you guys are, and how what we thought is actually not happening, and we enjoy the people that are coming through.
Great.
So we're changing the hearts and minds of some of our locals that were concerned.
That's great. So that goes to more education for the community,
Right.
because what you don't know, sometimes we fear. So if they had a better understanding, then maybe they would be more, receptive to.
And with the amount of clinics, I don't want to say clinics, the amount of programs that we have, that we can say, here, come visit any of our local programs. Come visit us. It's an open door policy. Walk in and say, who are you? What's the client experience like? And when we go into facilities or into towns and we invite them, just come over and check out. We're only probably a half hour away from where you are is another facility of ours.
Right.
And you can check that one out and see what impact. Go talk to the neighbors. And because we're the size of a female salon, we're usually next to, our Brockton has a Pentecostal church on one side and a music store that teaches children how to play music and sells guitar and drum day. Every day I go in there, someone's being taught how to play drums. But but they're right there.
Right.
And they were concerned, but now they're not a concern at all, and they welcome us grandly.
That's great. That's great. Now, let's talk about the book.
The pandemic book actually was part of for us to write down our stories, and our CEO's story of his recovery, our medical director, his story of what they had to do, and how they fought their addiction and how they won. And then turn that win into creating recovery connections. And our CEO, when we were getting challenged by town councils, or that they would do a background check on our director and say, well, he's got a kind of shady past. Why would we let a shady past have a business here? Well, instead of having them try to do a background check, we're being forward.
Right.
And he wrote this, and I added a little bit, but there was definitely, and then we have client stories, the most important part of all the clients' recovery stories about MAT.
Okay.
The book also then as kind of buprenorphine or MAT 101, what to expect.
Okay.
So it's more of a client book. It's a great way of just breaking the ice, The Silent Pandemic. It's on Amazon. Amazon's actually you buy books. The Kindle is 99 cents, and
Okay.
the book is like I believe $4.
Wow.
And the 20 cents I think we make on it, we send to a food bank, or we send to. We don't make any money on it. We make sure that money goes somewhere else
That's
because this
great.
is just to help, and we hand it out freely.
That's
So every
great.
client that comes in receives a starting package from us. People that are homeless, so we also add an extra homeless care package for
Okay.
them, and the book is always there.
That's great. That's great. Now, what kind of support do you all receive, or any support like from the state, the city?
We are privately funded.
Okay.
We are, you would say, I hate saying we're a profit, because our profit, as you can understand how many new offices we're opening on a
Right.
monthly basis, we're self-funded, and that it's a Recovery Connection Centers Inc.
Okay.
And we don't take outside state or federally funded money at this time.
Now, was that
But we are CARF accredited.
Right.
We're BSAS accredited through
Right.
the state as well. So we do things
By the
by the
right.
books and by the regulations.
Right,
We have oversight to make sure that we are not doing anything
Right.
that we monitor.
Right. Now, was that a mindful decision of the CEO, or did it just kind of work out that way?
It worked out. BSAS is the Massachusetts equivalency, so it's kind of the good old boy network that we want to make sure in Massachusetts alone that you're doing it right.
Right.
As an outsider, when we were doing it on ourselves and monitoring ourselves, you don't have their exposure. So us to qualify that, then they get to expose us as to saying, yes, we did all these incredible qualifications and evaluations by them, and our paperwork's done. Now they can promote us as well, as it is a safe, comfortable, accredited site to do,
Okay.
as well as our CARF accreditation as well.
Okay. That's good. Now, what about staffing? Do you see a lot of turnover? How does that work?
So, because a buprenorphine has a restriction amount of clients that a doctor can see by law of buprenorphine, we can't hire full-time doctors,
Okay.
except our medical directors, of course. So we hire nurse practitioners, psych nurse practitioners, retired doctors that want to give 12 hours or 15 hours a week, sometimes from 2 to 7 o'clock at night, maybe even 8 to 1 o'clock on a Saturday.
Okay.
So when we open up an office, a doctor may be there Tuesday, Wednesday, and Thursday for 4 hours a time. And then when that office gets more and more clients, if that doctor's cap number is starting to get approached, we can hire another doctor to come in other hours.
Okay.
And allow that. A lot of nurse practitioners like this model because it's kind of a little extra,
Right.
and they really enjoy, and we find and hire people of passion that
Okay,
want to work the
great.
population and understand buprenorphine treatment and want to do this because they see our model, and we're stringently showing them what is expected of them, and that how counseling is always on board.
Okay.
We are not a pill mill. We're not a push-through mill. We
Great.
take responsibility, and we want to engage that client and do whatever we can for clients.
Great.
As much so as if a client is in need in the community and calls us up and needs to come in, I'll Uber them in.
Okay. Great.
And then we can put a PT1 state transportation, but we will reach out as hard as we can.
Now, you take insurance. What kind of insurance?
Every insurance.
Okay. I saw a long list. Yeah.
So we take every insurance as well
Okay.
as even the military insurance, and that's our responsibility to do. And
Okay.
and we've had clients lose their insurance. We're not going to lose them. We will work
Great.
with them to get it back. We'll use some of the community support system to help us get that
Great.
client's insurance back. We've done we know it maybe is a donut hole for a month or two, and we will try to do something, and they will not lose treatment.
Great. That was going to be my next question. If someone comes and they don't have insurance, but you answered that. That's great.
We will try everything possible because of those other outside community resources to try to get them insurance to get coverage. But if a person's in need and they are in a life-threatening situation with opiates, that we will try to. If someone's coming in with alcohol issues, or because alcohol is much more deadly to come off of, we want a detox in there. a possibility of sending them over to a detox before they can come back out for services.
Great, great. Now, what is the length? How do I want to ask this? What is the longest that you follow a client that comes in?
This is, you're asking how long do they have to be treatment to be cured?
Well, well, no, because as we talked yesterday, that it's individualized. But okay, maybe let me reword that. What is the longest a client has been followed by you all?
For this, I presume Mike still has 5 or 6 year clients, because they might be on a low dose of buprenorphine. They may be on the same dose they started with, but their life has changed around in such a dramatic fashion that this is just part of who they are to maintain a higher quality of life and recovery. And so they could be here for a long period of time. Some may transition to another program, but we have I'm sure we have clients that have been there from the start. Mike still knows them, and when he's walked into because we have so many, when he walks in to the Providence area, he'll have clients come over and give him a hug and come over and know him right from the beginning. So yeah.
So because you all actually started in Rhode Island, am I correct?
Okay. Yes.
Okay. Welcome back. We took a little break, but this is The Best Is Yet to Come. I'm your host, Stephanie Seigle, and our guest today is Greg from Recovery Connection. Before we took a break, Greg, there was a question I wanted to ask you, and it escaped me, but it's back. Yesterday, when you and I was talking, you mentioned to me that you was on a drug task force. Can you explain to our audience exactly what that is and how did you come about to be involved in that?
So I'm on about 3 or 4 drug task forces throughout the state of Massachusetts, and one of them is the Brockton Recovery Task Force, and with the HEAL community, which is a survey group that came in from the government to ask questions to community health center, addiction facilities and programs, and this task force is to address the ongoing opiate addiction. And so they came in to do meetings with us and questionnaires for over a year of what is happening in each office, what's happening in each facility, what outreach and what approach is being taken. And what they're attempting to do is stimulate a understanding of what is working and what is not working, so they can actually report to the government here. We've done an extensive by area just in Massachusetts, and I don't know if they're doing it nationally, but I just know it through my groups in Massachusetts. And those gets us to sit down with Boston Medical Centers, their recovery programs, and listen to their staff, to small independent recovery houses and detox facilities, and it kind of, you get us all in the room that we have a tendency to talk, but it's more about what's working and where we can have awareness. And one of the big things that I took right away was like 6 or 8 months ago when the test strips came out, and someone said, "Oh, we now doing these test strips." And half of us raised a hand. Where are we buying these? At the time, it was had to buy them out of Canada, but now we can get them in the United States. However, it was that kind of influential part of these task forces, and sometimes a task force can be run by the governor's drug task force or an off branch of a major facility like BHN out in Worcester area. Boston Medical Group does there. New Bedford, the health department kind of does theirs. So it really comes down to, you can find your local one, and it was a really unique way of blending ideas and information of what's working. A lot of times they are FAQs, federally qualified healthcare settings. So a lot of the state, when we're talking about federal money coming in from pharmaceutical lawsuits that have come through, where's the money going to? What grants are available now? it didn't impact me in a way, but I'm a member, and I'm a member and want to make sure the money is being used wisely and smartly. So there's a lot of influence of them asking, where should we be spending money?
Okay.
And finding out the analytics of what is working, what's a good outcome, why are we not supporting that? If there's not a good outcome, why are we sending money to something that's not a good outcome? Or do we need to send money just because it's appropriately used to try to reach out the homeless?
Okay.
Food banks, to shelters, and to provide housing, and in that nature. So these, the HEAL study has helped generate even further deeper discussion of where and support each other, as well as identify and pilfer ideas off of each other, which is
Okay.
good, because we're all in it for one reason, is to
Right.
try to help someone else.
Right. Now, how often do you all meet?
That was on a month-to-month basis. The
Okay.
Brockton HEAL study that went on for almost over a year has just wrapped up.
Okay.
Now, I'm in the HEAL study in Springfield,
Okay.
so I'm a part of different HEAL studies that they then go and do these into the others, other task force in the state as well.
Okay.
So I get to be kind of like the professional HEAL, which is helpful, because then I can help spur on to understanding what it entitles in some of the subgroups and subcommittees that want to discuss certain specifics.
Okay. Now, you said the one in Brockton has wrapped up. Are you aware what was the outcome of that study? And is that something you can
That's
share?
they have to tabulate that
Okay.
and do that, I expect. So the Brockton task force is then, what are we doing next now that the HEAL study's over, because it was government money to do that.
Okay.
So we got money towards BMC to be able to run this kind of thing. Now that that's done, why aren't we still meeting in a task force way? And that's what they're trying to figure out, because they know it is a supportive community network that's all
Great.
now established.
Great. That's good. So you said a new one started in Springfield.
Oh no, that's the HEAL study is there. They used to their regular drug task force at meeting. The HEAL study came in and actually is now attaching themselves to it.
Oh, okay.
So that's how it kind of starts. So if anybody has that task force already, the HEAL will find you
Okay.
and say, can we be part of it, and help them out actually.
Okay. Now, when you said drug task force, I automatically went somewhere else thinking, because you know that when we hear, unless you're educating like you're educating us, and shared with me yesterday, do you feel that more towns, more city need to have this, and how do you get it started if so?
As my experience in the past year and a half on doing that, I'm hoping to convince them that they should have once every 6 months that all of them do one task force as a state
Okay.
committee. There's a number of facilities like Clean Slate that span throughout Massachusetts.
Okay.
There's a number of different addiction facilities that are large enough that are all over that they're on those committees. That's fine. But the smaller recovery center, the 2 or 3 in one place, may not know what's going on the Cape and Gosnell.
Right.
And then if we can have that in a centralized form, Zoom has been really comfortable and easy
Right.
for everybody to schedule
Right.
that, instead of driving the 2 hours or 3 hours to get to. That I would love to see that as something, and then take a hierarchy of someone to really understand what this is to the blending of Massachusetts supports and help and ideas, because there's definitely different pockets in Massachusetts with higher overdose rates.
Right.
They have what's called a gray model, and they'll put up a map, and it will show these gray zones and where the people are overdosing the most, and where in which town and which city. And a lot of town councils make it very blindsided to their issue,
Okay.
and just one town over doesn't, or one town over is even worse, and they don't even talk about that. So we need to make it more of a
Right.
citywide, statewide.
Right. Now, are you privy to some of those gray areas that we see?
Privy meaning that we can ask usually the Department of Health
Okay.
gives us, and there's I know there's a couple government websites that can put that out as well.
Okay.
But every time there is an overdose, every time there's a death, doing that. Even a Narcan event, they have to register that, so there is a tabulation
Okay.
that the state will have for us, and they can generate our gray lists.
Great, great. Now, I know we talked about a new location that's going to be opening.
Which one?
Oh, how many do you have that's
All right, I always like trying to do this because they come up. Hyannis is currently open, just opened. Fall River will be opened within a month. New Bedford, we're looking to open soon.
Okay.
Dartmouth, and then coming up 24, you have Taunton, Attleboro. Plymouth is open this past week.
Okay, great.
We have Brockton that is open right near the Westgate Mall.
Okay.
Then we swing over to Dedham, up to Burlington. We're waiting to open up Lynn.
Okay,
We're waiting
wow.
to open up in a week or 2 weeks. And my CEO, I can hear him going, not yet. In Roxbury, right on
Okay.
Tremont Street. We're in Worcester. We're in Springfield, and we're looking for other sites as well in Massachusetts that we know that we can enter in and be like, wow, that's a lot of sites.
Right.
Remember, we're a nice, small, comfortable model.
Yes.
And because of that low overhead of a small space, that we can treat people appropriately, comfortably, safely, but with counseling and the right amount of community supports that is available to us.
That's great. Now, correct me, but
Oh, excuse me,
Okay.
Roslindale.
oh, okay.
He's got here. I'm like, did I get them all?
Okay. Okay. So that's quite a bit.
Yeah.
Right. So, my goodness, you already have 16, correct yourself, Stephanie,
Right.
16, and you're going to be opening up.
Manchester, Connecticut, and possibly Hartford, Connecticut. We're waiting for state approval. We have a place in Manchester. We're waiting for Connecticut state approval. We're looking in New Hampshire next, just over the border in Nashua. We're looking into Maine as well. We look at this model as that we're able to financially support ourselves because of our low overhead approach,
Great.
but an effective approach, and that we're going to continue to use it because we have a high retention rate.
Okay.
And that's where the analytics is. If a client likes us and continues to return and is getting and is able to gain recovery and stay with us, it helps us open the next place.
Right.
So if we were doing bad work and nobody showed up, we wouldn't be able to expand.
Right.
So we're doing something right, and we know we
Absolutely.
are because of the experience. Our website, drughelp.com, is our website. Our book will help them along, and this is what we are expanding. And we help out offices that my prior job as helping people get licensed and trained to use buprenorphine. I know a lot of different facilities and practices that may need our support if they retire or want to step away from buprenorphine treatment. We can help them out as well, and we've been able to help those as well.
Okay. Now, you said earlier when we were speaking that the clients are able to talk about what to expect from their treatment. What does that look like, or what have been shared with you, how that looks?
Meaning
The mat, using the mat.
right. So buprenorphine treatment is started by someone having to stop their opiate for at least 24 hours.
Okay.
And that's a soft opiate. Oxy, Vic, and Perk are soft opiates, meaning they fall off quickly. A person's going to enter into withdrawal real quick. So it means it's fallen off what's called the receptors in the body. So a person has to be under mild and moderate withdrawal before starting buprenorphine treatment. Once buprenorphine is started, it stops the withdrawal, stops a free fall into withdrawal that first day of being on buprenorphine. The second dose of the second day stabilizes that body further, that covers the receptors with buprenorphine to stabilize urge, craving, and also starts as a blocker. If a person tries to use opiates again, it will block opiate use. So buprenorphine needs to be taken correctly.
Okay.
First and foremost, if they're taking it orally correctly, and I think we talked about this yesterday. And once they've taken it, usually that first script is once a week, as we said,
Right.
and then they can progress on. I think the most interesting thing that I learned was clients were not taking their oral medication correctly.
Okay.
It is called Suboxone. That's the trademark. It's a film that looks like a Listerine tab
Right.
that's placed under the tongue. It's then dissolved within about 45 seconds. It used to be in a pill form, and at a pill form, you put it under your tongue, and it took 10 to 15 minutes to dissolve. You had to keep your head forward to keep the medicine in your mouth, up in your front, what's called the mucosa, to be absorbed in. It is not a medication to be put into your stomach. It doesn't absorb that way. So that experience is very difficult for twice a day sometimes. Head forward and not speak, not smoke, don't
Right.
drink or anything. So the Suboxone film trademark is but it dissolves in 45 seconds. But the experience to be absorbed is at least 7 to 10 minutes. So even though it has a very bitter flavor, smokers, don't smoke.
Okay.
If you're having your morning coffee, don't drink it because it's being absorbed. We're so much of an American that I have a headache, I'll take an aspirin
Right.
in our stomach. This is different. So don't smoke, don't drink anything for at least 7 to 10 minutes. Because as the film dissolves, it's less likely to form a lot of spit,
Okay.
where the generic tablet may, because it's still breaking down and it stimulates that glands to spill more spit that you're not allowed to swallow.
Okay.
After the entire experience of time is over, you do not have to swallow. It has nothing to do with putting this medicine into your stomach. So people say, oh, it upsets my stomach. Why are you swallowing it?
Okay. Okay. So that's the reason why you say people are not taking it correctly.
Correct. Because if someone on the street, because buprenorphine prevents withdrawal, it stops the free fall of withdrawal.
Okay.
That someone on the street you can't find a dealer to give them their next hit and they're into withdrawal, but they give them a Suboxone. They're actually mild to moderate withdrawal and they've taken the buprenorphine, but nobody told them how to take it. So if they put it on top of their tongue, they're going to get a very minimal amount that might at least give them something, but not even close to. So we want to make sure how to take it correctly to get the correct dose into your body, and that state will be stabilized. If a person is having difficulty, and this is from either the homeless or households that have the oral medication present, and or having to go into a pharmacy to buy this on a monthly basis, there is what's called Sublocade, which is the injectable form that is injected at our office. It comes to our office in that person's name. The insurance cover it. That is a high dose of buprenorphine that lasts over a month. It's a once-a-month injection. But then you don't have to worry about if you're putting it under your tongue correctly.
Right.
You don't have to worry about someone stealing it, or you having to sell half of it, or manipulate part of it, or not take it correctly.
Right.
This is so we have people that are, my favorite story is a gentleman who's a boater, that he's off in New Bedford and goes out for 40 hours a week, and he takes some buprenorphine, and he's up for so long he doesn't know when to take it again. And he said, if I have a shot and I don't have to worry about that, wonderful. So it can be a request to do that.
Okay.
Or if a person has been really struggling with a lot of opiates and in their treatment, and they've been manipulating it at times, but they have clarity at times, like, I really need help, the shot may be a very strong alternative for them to have. So we definitely utilize Sublocade as well as a source of treatment.
Okay. Well, my producer just came out. Greg, this has been an awesome show. Thank you so much. But before we wrap it up, I would like for you to speak into the camera and say what it is, some parting words with our audience.
Wow. Well, Recovery Connection is there for you. Our access is immediate. If you called us today and said, I need help, we're going to treat you today or tomorrow. We have enough recovery facilities in Massachusetts that even if my doctor is not there that day, our manager is, and we can get you in there and Zoom call down to a doctor to be seen that day, and then do a formal intake to when that doctor is there. We want to know that if you're in need of help, we want to make sure that the help is granted then. Our support, we cover your insurances for our population of different cultural needs. If someone who's not fluently in English of different cultures, we have the capability of using your insurance for interpreters. And immediately, even on that day that you walk in and said, well, I need help, and they don't speak enough in English, we have an app that we can use to immediately help translate and use that the translation line to help you. And from there on in, we can use your insurance to use a translation help. So we welcome you to call us up.
Can you give your number too?
I don't have it off the top of my head. So drughelp.com. That's help, H-E-L-P. So drughelp.com. And we'll have one phone number on the line. And I'm sorry, I don't have it right off the top of my head, and my CEO is going to yell at me. And that one line will give you access to all of our offices, and we'll give you the list of that. And someone will always pick up the phone for you.
Thank you.
Thank you for this opportunity.
Yes. Well, once again, as I said, we've had a great show. And as you know, before I do this, since it's Father's Day, I want to wish all the wonderful fathers happy Father's Day in advance, and enjoy Sunday. Well, in closing, I bid you peace, love, and blessings, and remember, the best is yet to come. Thank you.
The best is yet to come. Your best is inside of you. Your best is